All right, so we're gonna do chapter 12, which is mobility. Okay, so this chapter 12, at the end of this lecture, hopefully we'll be able to examine the drugs used to treat myasthenia gravis, including the action, side effects, and priority nursing considerations, plan nursing care to administer medications to treat myasthenia gravis. So this is chapter 12, but this is only cholinergic drugs. The other thing I want to say is that I made this PowerPoint. This is not really the one from Pearson. So there's going to be some information that may not be in the book, okay, especially on your drug cabinet as well. So you can read the chapter just to refamiliarize yourself with the cholinergic drugs, but we're going to go by what's on the drug cabinet, okay? The book's just missing a lot of information about myasthenia gravis, okay? All right, so cholinergic drugs. Remember, they're divided into two subclasses. There's direct binding and indirect binding. Direct binding bind to cholinergic receptors to produce rest and digest response. That's the bethanochol. Then there's the indirect, they inhibit the action of acetylcholine, and they have a high potential for serious adverse reactions. That's the neostigmine, okay? I feel like we're going to talk about some of the other stigmines when we talk about myasthenia gravis, okay? So what is myasthenia gravis? So it is an anti-acetylcholine receptor antibodies. So this is a lovely picture right here. So these acetylcholine inhibitors, antibodies, don't let them attach to each other. And if you don't let the acetylcholine attach, you will have like decreased muscle weakness. A lot of times it starts in the feet and like works its way up. Okay, so in the feet, you'll start getting numbness in your feet and then your legs and then further up and up. Okay, so you can have ptosis or diplopia, which is, your ptosis is your eyelid drooping. Diplopia is double vision. You can have phonation, which is how things turn. It's harder. You will have like a natural rotation. You'll have problems chewing, problems swallowing, difficulty with ADLs. Okay. So Edrophonium. Edrophonium is the medication they use to test for myasthenia gravis. Okay, so it's for the diagnosis of myasthenia gravis, to treat myasthenia gravis as well. So it inhibits the destruction of acetylcholine by cholinesterase, facilitating transmission of impulses across the myoneural junction, which is that little junction we saw on the last slide between the neuron and where it sits, okay? So adverse effects: respiratory paralysis, bronchospasms, laryngospasms. If they're over 50, they have an increased risk of bradycardia, hypotension, cardiac arrest. So think of it like, so it inhibits acetylcholine, okay? We know that cholinergic drugs do the rest and digest, right? So if you're over 50, they can work too well, we can have the bradycardia, hypotension, okay? So medications that we want to avoid: procainamide, quinidine, no foods, the treatment overdoses and myasthenic crisis. We will talk about the two of them. There's two different types of crises. We're going to talk about those in detail. Contraindications: cholinesterase inhibitor toxicity, interstitial or urinary obstruction. Okay. Remember way back then about the urinary bladder neck relaxing and things like that from the cholinergic or anticholinergic. Okay, so we need to monitor vital signs and respiratory status. If they are taking any of these medications that treat myasthenia gravis, so all the cholinesterase inhibitors, they need to stop them at least 8 hours before the test, or then that's not going to matter. Okay. And then a positive response is a brief improvement of lingual or skeletal muscle movement. So like improvement of your movement in general. Okay, so what they do is they inject it, like I think IV, and they put like a TENS unit on your leg as well, and they can monitor if like it's actually doing what it's supposed to do. Okay, so it's like measuring how much your muscles tone. I watched my grandmother get it done. It's kind of anticlimactic. Okay. All right. So myasthenia gravis treatment. So pyrostigmine and neostigmine stimulate skeletal muscle contraction and reverse severe muscle weakness. So The whole point of these two drugs are improvement of ADLs, okay? So they improve your mobility, they improve your how you walk, things like that, okay? They do not cure nothing, there is no cure for myasthenia gravis. This other medication, all of these medications treat myasthenia gravis. Abrupt discontinuation of any of them can lead to a myasthenic crisis, okay, which is extreme muscle weakness, similar to cholinergic crisis, and we're going to get into the difference, like how they differentiate the two. But what's important is if you give the medication and weakness occurs, because we don't want weakness. The whole point is that we want to improve weakness, right? We want to improve mobility. So if you give the medication and then weakness, extreme muscle weakness occurs within 1 hour, it is a cholinergic crisis, and we give them atropine. Okay, stop giving whatever medication it was and give atropine. If it's like IV. If it occurs 3 hours or more after administration, it is a myasthenic crisis, and you give immunoglobulins. Sorry, but it's important to know the difference in the two because they're very different treatments. Okay. All right, so myasthenic crisis. Myasthenic crisis is different than cholinergic crisis because this one has episodes of extreme respiratory failure. It will you're going to stop breathing. You're going to need to be ventilated, like mechanically ventilated. So you need to be intubated and on a ventilator. Okay. You have tachycardia. Okay. You have flaccid muscles, pale, cool skin. It lasts 2 weeks. Okay. The IV, that's a big deal if I'm not breathing for 2 weeks, right? IVIG and plasmapheresis to manage the symptoms, okay, and help get the medication out. When you have a cholinergic crisis, remember the cholinergic is the fast one. It's within the 1 hour, okay? This is an excessive amount of anti-cholinesterase meds. So the neostigmine that you gave me, it hit my system way too hard. That was way too strong a dose. And so I have that really fast reaction, okay? So stop the neostigmine or whatever medication it was. You have, I think it's supposed to say muscle weakness, bradycardia, not, so see how they're different, okay? Fasciculations, sweating, pallor, excessive secretions, so you'll start drooling a lot maybe, small pupils, remember that's meiosis, okay? We treat it with atropine. And the fasciculations is like a muscle twitch in your eye, okay? So you'll have like muscle twitching. Okay, so you see how they're different. One's bradycardia, one's tachycardia. One's flaccid muscles, one's twitching in your eyes. One's cool, dry skin, one's sweating. Okay, excessive secretion, and then the pupils. Okay, where the other one has the respiratory failure. So that's how you can kind of differentiate them, kind of opposites. So know which one's which. Okay, once again, we treat it with atropine. All right, so then we're going to go into the pyristigmine, which is one of the medications they use to treat myasthenia gravis, okay? It inhibits acetylcholinesterase by blocking the destruction of acetylcholine, okay? It's pretty fast onset, 20 to 30 minutes. Adverse effects are headache, syncope, bradycardia, cardiac arrest, bronchospasm, bronchoconstrictions, nausea and vomiting, blurred vision. So drugs we want to avoid, obviously, is anticholinergics because that defeats the purpose. Atropine because it's going to reverse it. Corticosteroids, magnesium, procainamide, quinidine. Avoid alcohol. Okay, and then we've talked about the myasthenic crisis and the it says atropine is the antidote because it is the antidote if it's within that 1 hour because it's going to reverse the cholinergics. Okay, the cholinesterase inhibitor part. So that's why it always says atropine, but we know that myasthenic crisis has a different treatment. So just keep that in mind. Okay. Contraindications: mechanical obstruction of the urinary tract and intestines, bronchial asthma, edema. I don't know where that came from. Bradycardia, arrhythmias, epilepsy, hyperthyroidism, and beta blockers, because we know those kind of reverse. There is a syrup available for if you do have the difficulty swallowing, so that's good. We stop all anticholinergics before you stop all cholinergics before medication that you administer them, monitor their response, stress the importance of taking meds on time and evenly spaced, okay? Because if you take them too close together, we can have those myasthenic crisis or that cholinergic crisis. And if you take them too far apart, it's not going to help you, okay? So if your patient has it at 8, 12, and 8, and at 12 o'clock, you know, they're going down for an x-ray or they're going down for a CT or whatever, you need to go with them to give it to them. It's got to be on time, okay? They need to wear a medical ID to identify the myasthenia gravis. Have atropine at bedside when giving IV, monitor heart rate, respiratory status, and for myasthenic crisis as well. Okay, and that is all of mobility. If you have any questions, please put them in the discussion board. Email me if you need to, but that's about it. Good luck.